Hello, everyone. I'm Kathy Lieblich, Director of Network Relations for Pioneer Network. And if you listen to the podcast with Jim, you heard me asking Jim questions. Welcome to the Virtual Learning Circle portion of our 7th Listen, Learn, Explore episode. We hope you enjoyed the podcast if you had a chance to listen to it. The goal for this session is interaction and engagement and an opportunity to talk to Jim and others who are joining us. And we encourage you to turn on your camera if you have it so we can see you. But if you're not able to, we certainly understand. There are a number of ways to participate. You can just unmute yourself and start talking, or you can raise your hand or type your question or comment in the chat. You can also use the reactions button on your toolbar to provide feedback. At the end of the conversation, you'll receive a link to a short survey to give us some feedback on the conversation. So Jim, would you like to say a few words to start us off?
Sure, I am really happy to be a part of this and have a chance to talk to all of you and learn from you about what I think is a really important tool in creating awareness around what it's like to live in a residential care setting. I certainly learned a lot during the 4 days that I was there, and I feel really strongly about other people doing the same thing. I'm just not quite sure how to carry out the logistics of that. So that's one of the things I hope we can kind of address today. But I'm glad to be part of this.
That's great, Jim. And also during the podcast, when Jim was asked what he recommends that staff do differently, he suggested they live in the home as a resident for a little while so they'll see their job from a different perspective. And someone did that. Leslie Pedtke, who's joining us today as well, had her staff do that and wrote a book about it called What Living as a Resident Can Teach Long-Term Care Staff, The Power of Empathy to Transform Care. Leslie, welcome. Would you like to say a few words?
Thank you. Yes,
Sure.
So like Kathy said, I did that. I had several staff members move into the nursing home and live there anywhere from 3 days all the way up to 11 days. And they did a lot of what Jim had gone through, where they lived like our dependent residents live in long-term care. And then we decided that we wanted to make sure that all of our staff experienced the same thing. So we made it part of our orientation program where all staff had to live in the nursing home for 24 hours before they were able to start any job that they were hired to do there. So thank you for inviting me.
Great. And it is a wonderful book that we happen to sell in our bookstore, but I'll stop with doing that. Yeah, it's really a great book I recommend everybody read it, whether you're in this field or not. So does anyone have any questions for Jim or for Leslie? And let's see if we can spur up some conversation that way. Judy.
Yeah, I do in reference, I've been working in this business for 30 some years, and all along I've realized that there is a definite disconnection between management and the frontline people. And I've been working on things to try to figure out how to, like Jim said, the logistics of making part of management, and I mean all the way up to owners and financial people, as part of their training and onboarding, and every year have to redo it to stay in a unit as a dependent resident for at least a week, because what I see is that there's that total lack of compassion from the management, that especially financial, that make decisions on where to cut and where not to cut. And I've been trying to work on something that will bring those two together so that, and then I found out that Jim had actually done it. So I was excited to hear what he had to say. But, you know, when you're looking at management that's making cuts as to how the unit is run, they need to know what it is that they're doing. They need to know what they're affecting. And it makes a huge difference if we can figure out a way to have them have the experience. They should know the names of their residents. They should know the names of their staff. And it would, I believe, it would change hopefully some of the decisions they make about where to cut. Because I ran 2 residential homes for 17 years, and I know it can be done. It's just a matter of management recognizing what it is that their decisions are affecting.
Yeah, I'd like to add something here to what Judy is saying. I think that a lot of owners and administrators probably think that they already know what it's like to live in a facility because they're there, they work there.
Yeah.
But there's a huge difference between seeing your facility from the eyes of working there versus seeing it and experiencing it from living there. So I think that's the big disconnect. I think a lot of managers would argue, I know my residents, I'm real friendly with them, I say hi to them every day. But until you are actually in a wheelchair or experiencing being a resident, I think you still don't have a really grasp, a good grasp of the experiential side of living in a facility.
Leslie, you have anything to add?
Yeah, and I agree with Jim. Whenever I did the experience with my staff, much of my management staff actually took part and moved in. My director of nursing lived there for 8 days as a dependent resident, and she said it was, and so did the assistant director of nursing. They both said it was really important if we were going to provide this opportunity for our staff to do. They both said, well, we have to do it, because if this is something that we kind of expect our staff to volunteer to do, then we need to do that as well. And I moved in to the nursing home as well. And it, what you're saying, Judy, and Jim, it's an entirely different perspective of what you get as being that person on the other side of the door, that person that's working and has that role, to then being that dependent resident that really relies on everyone. So you're absolutely right, Judy. I mean, I think it's extremely important for management staff to take part in this experience and see what it's really like. And if you're going to expect your staff to do something like that, then management should take part as well. I even, whenever we were doing it in our community, I even approached ombudsmen and surveyors and asked them if they were interested in taking part. Not that I felt like that they didn't know, but I thought, you know, it might be just a really cool perspective for them to, not that I felt like that they were doing a bad job in their role, but I just thought I would be so willing to provide that opportunity to them as well, because it really does give you a unique perspective.
And I do, oh, go ahead.
No, I was just going to say, Judy, I think as I was listening to this too, when we're looking at that different perspective and that comment you made about, and Jim, that oftentimes people feel they know it because they know the community. Many of us have been in the situation where we have been the family member of someone living in a community. And I think many of us in that situation have come to realize that we see our communities from a very different perspective as a family member than we do as a provider. And I think maybe if we leverage that there's a lot more people who have been in that family member role and help them see that, look how different it is to see this through the eyes of a family member than the eyes of a provider. Now, think about now how much different that is to see it through the eyes of the resident. So maybe that conversation could help start a conversation and a realization that, well, yeah, if I see it different as a family member, I sure would see it different as a resident.
Mm-hmm.
Leslie, were you going to say something?
No, I
Okay.
agree with that. I've been a family member as well, and you know, of a community that I owned, and my mother was there, and I couldn't believe that how that experience was so different from actually being there and operating that home to now being the daughter of a person living there. So definitely, even those perspectives it's so unique, and it gives you a lot of different outtakes for sure.
And my experience as a family member also was just horrendous. My mother was kicked out of 15 places in 7 years, and in and out of the psych unit for aggressive behavior. And I knew her, and they didn't. And I tried to tell them that she was an emotionally sensitive person, and that most of her behavior that I saw was not coming from she didn't eat or she had her pants changed. It was coming because she just wanted someone to sit and validate her, hold her hand.
Huh?
Absolutely.
Yeah.
Yeah.
They've
Sharon?
already cut it off?
Sorry, did you want to say something, Sharon?
Oh, because Tiffany didn't think they
Sharon,
were going to do it till the
sorry,
end
would
of the
you
month.
mute yourself, Sharon, if you can hear me? Because we can hear you. Sharon, not Sharon is it Anderson? Not you. Okay, I don't hear anything now, so that's good. So anyone else have comments, reactions to this? Have you done this? What do you think?
I have
I
an
do.
additional question regarding,
Jim.
again, the logistics of this. I'm wondering, Leslie, if you could talk to, or anybody else could talk to, what you feel the difference is if you were to do this in a facility that you were not familiar with or people did not know you. Because I'm wondering if you do it in a facility where fellow employees or staff members know, they can treat it in a different way, like, okay, we have to be really careful here, or this is an exercise. Whereas for me, when I went in, most of the staff did not know me, nor I know them. So I think it gave that whole experience a different character of being just another resident in a facility where I was not a staff person before.
So I had 2 people move into our community as part of that experience that were not staff members. One of them was Gary Glazner from the Alzheimer's Poetry Project, and the other one was Jeff All from, he has an architecture firm called Architecture, and those 2 wanted to move in as kind of doing the same sort of experience, really wanted to know what it was like for their professional roles. And I contemplated whether or not I was going to let the staff know that they weren't really residents, or that they were really just moving in because they wanted to know what it was like to be a resident. And we decided that we would let the staff know the truth, just because I didn't want the staff to feel like I didn't, maybe that I didn't necessarily trust, how they would behave or something like that. Do I feel that those 2 gentlemen got the same experience that they would have had the staff not known? I mean, probably not, but I do think that they both got a really unique experience as well. And then of course, with the staff, of course, all the staff knew that they were staff members. So there was no, secret shop, being a secret resident or something like that. So that was really our thing. I just didn't want the staff to feel like that I was trying to trick them or something like that. I would be curious, Jim, how did the staff of the community react whenever they learned that you were a person there, just living the role of a person with dementia, and that you really didn't have that diagnosis?
With a fair amount of humor, actually. Like some of them said, "Oh, I thought maybe this was going on." So I think some of them, suspected. Nobody was really upset or angry about it. But I think it is a different kind of situation. I totally understand what you're saying, because, you have trained, educated your staff to be very sensitive to this whole perspective. And I think it has to be a totally different experience if I were to have moved into your community versus where I moved in, So I think part of it for me is to have somebody go into a facility, into a community where perhaps not everything is being done as well as it could be. And I think that would even be a better learning experience for them.
Mhm.
But I don't know how to carry that out.
When I moved into our nursing home, I was very anxious about it. I was really nervous because by the time that I moved in, I felt like we had really made a lot of directed transformations, that we were really on that culture change train, and we were doing really, really well. From my perspective as an administrator, I was afraid that I would move in and see things from the perspective of a resident, and that I would feel so deflated, and that I would feel like, oh my gosh, all this work, and we really have not made as great strides as I thought that we had. And I was afraid that it would I would lose my momentum of making changes. And there certainly were some things that I thought, gosh, I had no idea that we did that. For example, I came back to my room from bingo, and there were two incontinent bed pads on my bed. They had made my bed, turned down my covers, and there were two incontinent bed pads on my bed. And I asked my care partner, I said, may I ask why there's bed pads on my bed? And she shrugged her shoulders and she said, I don't know, because that's what we do for everybody. And I said, but I'm not incontinent. Why are you assuming that now, just because I've moved into a nursing home, that I'm incontinent? So I had no idea that we did that. I had no idea that we automatically sort of judged or made someone feel less than because they now live in a nursing home, and we just made that assumption. So there certainly were a lot of things, and there were other instances of that as well, that they made me feel like that I wasn't capable of doing things just because I now lived in the nursing home. Not that they were doing, and they weren't doing anything they never thought about it. It was just what they do for a resident. And so I certainly learned a lot, but I was definitely nervous about moving in because I was afraid I would lose my excitement of making changes.
I hope it didn't, because it really needs to happen.
Yes.
I'm wondering, I'd like to ask either of you or whoever has had this experience. Have you had any incidences where you actually lived as a dependent resident, so you could not go to the toilet? You'd have to wet yourself if nobody came when you rang the buzzer.
Good question.
Now, for me, everybody recognized that I was, fairly high function, lack of a better word. So I did not have that much interaction from a dependency point of view with the staff. I was just there kind of on a respite basis. And the closest thing, two things. When I came in, I had to drop my drawers for the skin check.
Yeah.
So, I mean, that was one thing that's just routine, I guess. I mean, it's an extreme privacy issue. I was warned about it ahead of time, so it didn't shock me. And whoever did it, did it as discreetly as she could.
Yeah.
And then the other thing was the shower. When it came time for me to take a shower, I was asked whether I could do it on my own or whether I needed help. And I said I could do it on my own. So somebody kind of just stayed in the background to make sure I was okay. That was another example, I think, of respecting my wishes and my privacy.
Yeah, because all along all the years that I was a provider, but I was on site all the time. I mean, I didn't do cares, but I realized how most caregivers, CNAs, home health aides, whatever, are so accustomed to just doing things, like you said, Leslie, that they put pads on your bed, that doesn't mean anything to them. And I had a really concise plan, because our residents had middle to late stage dementia, and almost all of them needed some help. And the staff act like it's no big deal. you know, and I'd have to say to them, look, you know, I actually went out and bought these Velcro things. You can like, looks like a towel. You can just put around them because people don't want to come in there and be totally naked. I don't care if they have dementia or not. They still have feelings and things that make them feel very uncomfortable. People wonder why someone fights a bath. Well, I said to him, if you came in and stripped off my clothes and started washing my private parts, I'd kick you in the teeth.
Janice,
So, you know, there is such a large, the experience, I feel, somehow has to be made. And I'm talking more about higher up management, just because all I've struggled with through the years is trying to get the like financial people and the management that make decisions about where to cut, whether they cut staff or they do cut something else, to have them understand what that's like and to be left in the place that they have and have maybe staff not come to take them to the bathroom and they have to wet their pants. I mean, it's all about dignity and respect. And like Leslie said, you can't assume that everybody's the same.
And Judy, you know, that's why I said, I just said that it was an important question that you asked about whether whether either Leslie or Jim needed help to go to the bathroom. And
Yeah,
so
or to shower.
called someone to help them and how long that took and whether they did wet the bed because of it, which
Yeah.
I call forced incontinence,
Mhm.
you know, because someone's not there in time to take you, which could happen to any of us.
Mhm.
So it's an important issue too.
Kathy, Lisa has her hand up, so I
Great.
think Lisa.
Yeah,
question
and
for us?
Lisa, go ahead. Thanks, Jim.
okay, and I'm on phone. I'm on audio on my telephone. So, my question was about, and it seems a couple things. One is, it just seems like we're missing a whole part of the new resident. Jim, was there a focus on making sure that you were introduced with other residents? Were there questions enough about you where you could say, oh, well, you were, in this job, we know somebody. Was there anything done to start creating a social connection? Were you introduced when you were around other residents? Was there immediately an awareness of religious or spiritual preferences that the staff were they consistently still introducing themselves and making sure you knew who they were and what they were doing outside of the caregiver who worked with you? I was curious about that. And the other statement, just to make, where I work, we have invested in a virtual reality program called Embodied Labs. And I have to say, after listening to the podcast, I walked away thinking it's been really amazing in training staff about what it feels like to be a resident, but it's little clips, and then it's the education thing. And I thought, it's not the actual thing, but what if there was a virtual reality training that walked you through life in the day of, for people who, would be too uncomfortable to actually go to a nursing home or assisted living if that was an option. But it certainly left me wondering that. And those were my comments.
Okay. To answer your first question, which is a good question, I thought about that, but no, nobody really introduced me to anybody else. What there was some kind of wasn't a care plan, a formal care plan, but the staff were told what my preferences were. And a couple of the strong preferences were for me to get outside every day, even though it was wintertime, and for me to have a vegetarian diet. And I think both of those were a struggle for staff because it was cold, for one thing. And I don't think they had anybody there before who asked for a vegetarian diet, and they really had a hard time handling it. They tried really hard, but no, in terms of introducing me to other people or helping me socialize with other people, that did not happen at all. And I don't know, maybe people figured I was only going to, because it was clear that I was only there on a respite basis while my sister was out of town. So they probably didn't think it was worth the trouble of introducing me to everybody else if I was going to be gone in 4 days. To your second point, the virtual, I can't help but think there is so much that you would miss about the experience of living in a facility that is really hard to replicate if you were to do it remotely.
I'm thinking, it could be just another option for like training staff if you're not willing to ask them to live there. And Lisa, I was thinking with Embodied Labs, you might suggest that to them.
Yeah.
I'm sure they'd welcome your
That's exactly,
suggestion, Lisa. Yeah.
yes, that's exactly what I was going to do is talk with them about, this perspective.
Oh, great. Jenny Dill, your hand is raised.
Sorry, I'm going mobile today. It's a little tricky. I really liked that idea. I've always wanted to do this, but because of my age, my life experience, I didn't feel like I could be accepted as a traditional resident. So I think that something like the virtual reality might be a step in the right direction. But I wonder, does anyone have any advice for doing this as a younger person?
So Jenny, are you asking if you could move in and for them to not realize that you're not a real resident?
Yeah, that's kind of what I'm getting at.
Mm-hmm. Mm-hmm.
Like just to have that complete experience like Jim was describing.
Mm-hmm. Mm-hmm.
Yeah, I think that would really be hard. Unless you were a good actress, and you could simulate brain damage or something that just made you very less capable.
Mm-hmm.
I don't know. That's a really good question. I hadn't even thought of that.
But I still think that you would get a good perspective from the other side by the staff knowing that this was just an experience that you wanted to have. And because, so my staff that moved in, we gave them a diagnosis and they had to live the role of that diagnosis. So say someone's diagnosis was that they had a recent stroke. And so they had to live the role of what that would be like to have a stroke. So they were in a wheelchair, they wore weights on one side of their body, their arm and their leg, so that it would kind of simulate them not being able to move those things. They had to be helped to the bathroom. They had to be bathed, all of those things. And so it wasn't that someone was just there and capable of doing things for themselves. It was more that they wanted to do those things themselves. And then every day I went down with them and gave them challenges that our residents would experience every day, like their clothes would get missing. They had a fall and they were on neuro checks every 2 hours. Their family called and said they just couldn't visit today. They were incontinent. I mean, every single thing that our residents go through, I had the staff go through. So it certainly still gave them that a good perspective because they had that dependent role. They weren't just there observing.
By the way, I should tell everybody, Leslie did a video of that experience. Terra Nova actually carries the video. So if you want to see what it was like, how that was carried out, it's pretty real.
Jim, can you provide a link to a website in the chat or something that, or you could send it to us and we can send it out to everybody?
Yeah, let me do that after we're done.
That would be great. I think.
Yeah,
I think this whole conversation makes me think, and Jenny, you especially make me think of this because we've had this parallel conversation about, we talk about robotic pets versus real animals and the whole debate of which is better and which is right or not right and wrong. And I think it's the same thing in this experience. That absolutely the ideal experience is living in that community and truly being that resident. But if we can't make that happen for everyone, are there things that we can do that may not be the ideal experience, but at least give us opportunities to meet people's needs and whether that be virtual, however we do that. I think we don't want to forsake the goal of this because we can't do it ideally, because there's so many things in life we can't always do the ideal.
Leslie, I'm curious what kind of feedback you're getting to your book. I mean, are other people that you know of trying to carry out this kind of program?
I know of a few communities that did do the same program shortly after that we had done it. And I don't know of anyone of lately that has done it. And maybe Joan and Kathy, of some communities that have tried the same thing. So I don't know of any that have done it recently. But I know, Jem, you and I have a common colleague, Monica Plymell. She did it in her community up in Rockford many years ago. Joan, there was a community in Missouri that had done it. There was a community in Wisconsin that had reached out to me that didn't do the full immersion, but did some kind of exercises with their staff that was, they wanted them to kind of experience, but they did not have the full immersion with their staff. But like I mentioned early on that we knew that not every staff member had 3 days, 8 days, 12 days to move into the nursing home, but we felt like everyone had at least 24 hours to move into the nursing home. And so that is what we did. We had everyone actually move in. They had to live there for 24 hours with another resident, a resident that was currently living there. We called it our elder shadowing program. So they had to move in, they had to live with this particular person so that they could just get even that 24-hour perspective. And then they had to write me just a really short essay on what their experience was. Every single person said it is tiring to sit in a wheelchair. Their back hurt, their legs hurt. It was sweaty, it was yucky. They were bored. They said they were so bored sitting there. And I made them, tell me, okay, so now that you're coming here to work in dietary, maintenance, CNA, and housekeeping, it was every role that you were hired for. Everyone had to do that. What are you going to do starting out in your role that is going to be different? How has this experience changed what your perspective was when you first decided to take on this job? And so it was really, they all said, one person especially, she said, what I really love about this already is that I felt like we're just sort of this mash of people and we're all here for the exact same reason. And that's what I've already observed with the staff and with the people living here, that we're just all one big family. I didn't have our staff wear a particular color for housekeeping or CNAs or dietary. And she said, in our name tag said advocate on them. They didn't say that that person was a CNA or a nurse or maintenance. They all said advocate. And she said, I love that because I could already tell that we're all just this mash of people with the same goal in mind, and that's to advocate for the residents. And so it gave them that perspective on how to be an advocate for the residents, because you can tell someone you need to advocate for the residents, but some people don't even know what that means or what that's supposed to look like if you don't know what you're advocating for.
Leslie, when you gave when you mentioned being in the wheelchair all day, reminds me of in the podcast, Jim told a story of a resident, of course, living with dementia, because he was in a memory care place, who kept getting up from his wheelchair and kept being told to sit down. And he said, and I think he maybe wasn't that verbal to begin with, but he said, my back hurts. You try sitting in that wheelchair all day. All day long. So, that's a really important issue in terms of, transferring people to regular chairs and all of that and having them sit somewhere else.
That was one thing that I thought we learned and really changed in our practices, that wheelchairs were for mobility only. They were not for permanent seating. And our staff really learned that from having to sit in wheelchairs themselves.
That empathy. Yeah. Sharon mentioned Sharon DeBoe. I'm not sure how to pronounce your name, Sharon, but Sharon said, we didn't do a live-in, but our orientation included staff being showered, assisted with a meal, assisted with, I'll say, going to the bathroom, and wearing Depends and other things.
That's great.
That's good.
That's a good idea too.
Yeah.
Anyone else? Comments, questions?
Let's say I am aware of a community that did a modified experience, and you're right, the wheelchair was something that they said, and even staff, one of the other comments that staff made was that they were amazed how after sitting in the wheelchair for an extended period of time, when they stood, how much their legs felt like jello. And these were people that were healthy, you know, and so we wonder why we have falls, and yet we, you know, it does kind of spark some light bulbs in terms of why we get some of the outcomes we get, because of some of the things that we do, well-intentioned,
Yes.
but certainly unintended outcomes.
So another, question, if for those of you who did listen to the podcast, what were your takeaways from it? Anybody? You can just chime in if you have. Rick.
Rick, you're muted, I think.
You're muted, yeah.
We may be better off with me muted. I don't know.
No.
This is an extremely productive session for me. I'm a geropsychologist at K-State, and I've had some experiences with culture change and the pioneer movement and whatnot in the state of Kansas and with our people. One thing that strikes me as on the research side is Jim's experience of going in and serving in a role that sociologists would call a total participant. And it's an experience, and it's an experience to be shared with applied practitioners, administrators, et cetera, but also with researchers who are interested in doing evidence-based research on culture change or degenerative movements in nursing homes. And I think that, and I don't know if we've talked about it, Jim, but it may be that your experience is something that should be in the literature and published for. And the reason I say this is this: you all may know who Steve Shields is. He's the guy who was a former administrator at Meadowlark Hills here in Manhattan, who is oftentimes credited with having an epiphany that led to the culture change movement in nursing homes. And the one thing that came to mind is one of the reasons he said he had this epiphany was the day that he was with his mother in his own facility and saw people running in and out and taking BPs and checking on her, and one after another. And it was at that point a medical model home. And he said, that was it for me. That was the moment that said, this has to stop. Okay. So I thought that historical kind of event was repeated here today in the sense of the different kind of perception you get when you're on that end of the facility. But my point being with Steve is, early on, I kind of had a running argument with Steve about doing research in his facility at Meadowlark. And I said, Steve, this is a brand new movement. I said, there's got every place to go here. What about research? And he viewed me on the academic side of things, and so I was a researcher, and he felt that he had enough training about the research and that this new era needed to move in a different direction. He said, well, Rick, let me ask you a question. If you had an animal or a dog that was in a cage, locked in a cage, and food was put in and it would eat, but it would defecate and scratch and try to get out and just having a terrible time in this box. He said, do you really think we would need a researcher to come in and validate the fact that things should change here? I said, well, that's a great argument. And I said, probably not. I agree with you. He said, we've got to let it out. And I said, absolutely. But, there will come the next stage, perhaps. We want to see for whom does this work best? How can we tailor services and attention and sensitivity and training and everything to different residents and whatnot, and looking at it in an environmental sense of the staff end, the environmental, physical sense, the families, the residents. It's huge ecology. And I said, these ecologies aren't necessarily all the same, right?
Mm-mm.
And so he just at that point wasn't very interested in cleaning up the little stuff, I suppose. And the big thing was get on the board first with the change, and then we can worry about that. But I don't know. I went into a meeting of nursing home administrators once over in Topeka. I was invited in, and I gave this message to them of what I thought was needed in terms of more research on culture change. And I can tell you, I ate lunch by myself, even though I was the invited guest.
Mm. So Rick, Rick,
Steve,
yeah.
It could have been me, but
Yeah, no. Steve had a point for sure, but research really is needed, and there has been a lot of research because everything nowadays is, well, where's the evidence base? What's the evidence base for this? And so we have our research consultant, whose name is Amy Elliott, is doing has done like a review of the literature, and is going to be there's going to be lists available of all the research from a number of years ago till now, having to do with person-centered care, culture change. There hasn't been research much really on the household model, which is what Steve built at Meadowlark. But on the greenhouse model, there has been, which is a small house also, but a little different from households. So as soon as that's out, we will have that on our website, and then you can look into the research. But the research is important because that evidence base is all they want to know. We also have, Rick, and everyone else may know, I don't know, something called the Artifacts of Culture Change tool, which is something for individual organizations to get a team together and answer the questions that are in there as to whether their particular practices, person-centered and culture change practices, there's a version for nursing homes and one for assisted living, where they either put that it has not been implemented, is partially implemented, or fully implemented. So that's something for self-assessment, that homes can use in terms of their culture change journey.
excellent.
Judy?
Yeah, I just have one thing to add. My experience is, well, I have done research with the university on our model of care that we built, but I was coming from a non-healthcare background to start these homes for people with dementia because it was a memorial for my mom. And what I did was a lot of research, a lot of studying. I traveled around the country for my job because at the time I was a regional manager for a barbecue rib company. And I stopped at places in the evenings when the management wasn't there and asked the staff what worked and what didn't work. And once I started doing it, I realized that yes, research is important. But when you're doing dementia care, you have to be flexible. Everybody is a different person. And there is no book that you can write and say, this is what you do when this happens.
Yeah.
But I think, Judy, that's also foundational to this movement, is that it is all about individualized care and services.
Right.
And I think sometimes we were less likely to see that individual in someone living with dementia. So it definitely bears, further discussion.
Yeah.
I did want to look, we did have a couple of comments here. Renee, and I hope I'm saying that correctly, from Canada. Thank you. We have a couple of people from Canada. She said, I apologize, Renee, I'm not sure if it's, Renee
He,
said,
she, or they.
I'm going to get myself in trouble here. Your staff observes, has the observation of lived experience of residents living in dementia care using the Butterfly Project from the UK, where staff experience what lived experience of people living with dementia households based on Kitwood's model of person-centered care. And we actually had David Sheard. The last time we were able to gather live, I believe David was with us. Lots happened since then, and it's an incredible model. And actually, Peter Buert, who had worked with David, is one of the speakers at our. This is a blatant plug here at our June 16th symposium that is all about envisioning dementia care. So what a great comment and a wonderful experience I'm sure you've had. And there we go. What a beautiful face. Thank you. Did you have anything to add?
Yeah, it's Renata. And
Renata.
yeah,
Oh, I'm so sorry.
we did a video of the before and after when we transformed a unit into a household. And we've been now on the journey since 2015, and we have 4 butterfly projects, and there's 10 in Ontario. So we're really looking at culture change, and we've worked with Norquest, and it really is about the lived experience. I would come in the evening to see if things had shifted back to a medical model, and I'm proud to say they haven't. But it's constant training. It's when staff are really given the time to sit and be with and not do to, that they really learn, and they've really embraced it. And yeah, it's been fantastic. And we had a new purpose-built butterfly project, and it's got the little households. And we've not only done it for dementia care, but for people with complex medical needs. And it's been unbelievable. And during COVID, we've done a lot better with the projects that we've had with the butterfly and losses in life and the whole lived experience when we had to isolate, because the staff really knew the residents and they were given the ability to be with and thrive and be in the moment. So it's been it's been hard because we've had to fight IPC, all those things, but you'll love Peter. He's a delightful person, and he comes from the clinical field. And I'm a rec therapist. When I first rec therapist to go in a hospital, guess what? People weren't dressed for 2 years. I said, can we get them dressed? And half of them went home.
Renata,
delightful to join you. I love the Pioneer Network, and we need to expand it to Canada.
Oh, it is. It's Canada's part of it for sure. Renata, Sharon Anderson, I just want you to know, who's here with you can see her smiling face, said Renata Sansbury's lifestyle options is fantastic. She said in the chat. Renata, what's the organization you're with?
It's called Lifestyle Options Retirement Communities.
Oh,
yeah.
Okay.
And we're going to come and speak, and we'll show you the purpose-built model at the Pioneer Network.
Right. Wonderful.
Right?
Yes. Yes.
That would be Denver in 2022. There we go. And we hopefully will be back together in
for the
person.
request for proposals later.
There you go. Jenny's from Denver. That's why she was doing the little dance there.
Yes.
Rachel,
we'll have some data and research, because we really did Life My Way, Living Well with Dementia, and we reduced antipsychotics by it was first 72%, and then it went up to 89%, and all kinds of responsive behaviors. So it's quite interesting.
Wonderful. Yeah, great that you're doing research. Rick will be happy about that too. So important.
We had another comment from Rachel. Rachel says she's new to senior living industry. It's been fascinating to hear about the movements to improve quality of life for our elders. Yay. These types of conversations need to be happening in open in our society at large. Isn't that the truth? Mm-hmm. Everyone ages, so everyone should be interested in their future care. And maybe that is one of the bright spots at the end of this pandemic, is that there has hopefully been raised an awareness of what life is like for seniors, the value of seniors, because we've certainly seen the other side of that through this pandemic as well. And some of the research into that has actually made it into mainstream media about the value of person-centered practices and that culture. It just as you said, Renata, in how that has impacted the outcomes for so many people. So hopefully we've got some good things that we can leverage as we move forward. Jim, any thoughts? Or
I just want to throw in one other question that I have, and I'd like everybody's response to it. One of the things that I think is fairly subtle, in fact, I didn't really realize it until I was there after a day or so, was the kind of tone that people had in their voices, particularly when women caregivers talked to women residents. And I just wonder if anybody else is really aware of that, and if it's an issue. If it is, how do you train people to not talk to residents as if they're children?
This is Lisa, and that actually was the thing I was going to bring up, Jim. That was to me resonated from your observation, because that's kind of been something I've worked on a lot. Is when I'm doing training, really emphasizing the elder speak. Because, you know, quietly it's demeaning to residents, and oftentimes it's overlooked. And I unfortunately, I've found even with the training that I do and the awareness, it's like so ingrained in staff, and also it's majority of female staff as well that I've observed, as opposed to male. And I mean, I have teaching moments where if I catch somebody, I try to re-educate them. But I think it's kind of this silent thing that goes on that's a real contributing factor toward, you know, just kind of disrespecting people without realizing it, and the effects that it does have on our residents and how they feel about themselves. It can create that self-fulfilling prophecy over time that I can't do anything because, you know, that's the perception they're feeling from others.
Yeah, absolutely. Leslie, how did you tackle that?
Well, I just think, you know, as I listened to that in your podcast, I was thinking the same thing. I think it just takes a lot of education. I think people don't realize they're doing it. My mother-in-law does that. So, you know, when she's not a caregiver, she doesn't live in a nursing home, but I observe her doing that to people that are older than her. And so I think with your staff, it just takes a lot of education. I think it's something really important to talk about upon orientation, for people that have worked in communities before and for people that have never worked in communities before. And it just takes a lot of education from the get-go and a lot of re-education. People just don't realize, I think, that they're doing it. And you had mentioned, Jim, in your podcast that you didn't know if it was kind of a maternal thing. And I think that, I mean, I would guess, I was giving that some thought after you had mentioned that. I thought, well, I guess it probably is a little bit, because I too, the few male CNAs that I have had, I never observed them doing that. So I think it probably is kind of a maternal instinct that you do. It just takes a lot of education.
I think one of the ways to get at it from a training point of view is to actually validate the intention, kind of the subconscious intention of talking to somebody that way.
Mm-hmm.
But then you have to ask the question, it's certainly appropriate to talk to your baby this way, because you're kind of demonstrating your maternal care, and you want to involve this child.
Mm-hmm.
But think about if somebody spoke to you that way, how would you feel?
Mm-hmm.
I think you have to get at these underlying issues of, yeah, there's a reason why people do this, and it's at a very subconscious level, I think. That's why it's so hard to get rid of, because it is so kind of subconscious. You know, we do it naturally almost.
Mm-hmm.
But it's been aided and abetted by the whole ageist culture that we live in.
Right, right.
Yeah, I was going to say it's so true of any ageist remarks that we make or the way we behave toward our elders.
Mhm.
And it's that same thing, it's awareness. You know, I've done some workshops on that for people, and it's amazing when you're after you teach them the things that they learn, because they at the end of this workshop, they have to say what they're going to change or be more aware of going forward. And then you realize, oh, they really did learn something, and hopefully they will follow through on it. But yeah, it's really important.
And
Jenny, did
Kathy,
you
I don't know
have?
if you saw Jenny.
Yeah, Jenny, and then there's a question in the chat after that I think is an important one too. Go ahead, Jenny.
So that part really, really stuck out to me as well. Because I observe it, but it also really challenged me to do the internal work. I have caught myself doing that several times this week, or observed it in others. And I remember coming back from the Pioneer Conference after listening to David and doing some of the observations as part of the butterfly model. And I think that is something that would be really helpful to do with staff. But for me, the takeaway for me was not so much the way that I speak to my elders, because I don't feel like I use elder speak very often, but I've caught myself talking about them to their families in a way that was not as adult-like and honoring as I had hoped. And again, like that, to validate the subconscious of it, there was nothing, I didn't mean anything by it, but saying like, oh, your mom is just the cutest.
Mm-hmm.
Which is something I say frequently. I get so excited, but I could choose a different word, and I could reinforce their elderhood, their adulthood through the way that I speak about them. So that was,
and that cutest thing, cute and cute, all that is something a lot of people say. It's one of the things that get me, you know, when people say it. But yeah, but it's that awareness thing, and then thinking of the best way to say to them, to make them aware that's not really criticizing them, is really important too. I did want to go to this question by Morgan Rhodes, who is an ombudsman and is here. And Morgan, I don't know if you want to show yourself if you can, but had a really, I think, important question. So the long-term care communities that he knows as an ombudsman, to his knowledge or her knowledge, I don't know, that's another he, she, they thing, have implemented something like this that they know of. But they said, I know that, so they take some online courses, but she they want to know, do you have any advice for us, ombudsman or anybody else, on how to broach this type of thing with the homes? Morgan knows that several are working on culture change, but this kind of experience they think would be beneficial for all staff. Any suggestions from Morgan?
Read Leslie's book.
Yeah, that's an idea, would be to suggest to the administrators and others that you come into contact with, first the ombudsman, also to read Leslie's book. I'd agree with that. But Leslie, any other advice?
Yeah, and Morgan, I would be happy to, have a call with you to kind of discuss how you could broach that with communities, and I even would be happy to talk to communities. And I think some people think that, well, we could never do that. I mean, whenever I have spoke about this at conferences, people would say, well, but I could never do that in my home. Why not? I mean, people would say, but we're for profit, or we're this, and think, so are we. And or we don't have the staff to do that, or we don't, there's always a reason why. But you know what, you just have to be willing to take a risk. And that's what culture change is about, is taking risks. And you just have to be willing to make that step, because it's worth it. It's totally worth it.
So on that note, we've come to the end of our conversation. I want to thank everyone for joining us and for this great conversation. Really, it's great to have that interaction. And thanks so much to you, Jim, and to Leslie. So everyone, please remember to fill out the short survey that you'll receive soon, and come back for another virtual learning circle for some of the other episodes for the podcast.
And